When I was a medical student, I was walking home through the Arboretum in Ann Arbor one day, and I had a really light step, and I was actually kind of singing to myself. And those of you who know me wouldn't be too surprised by that because I'm generally an upbeat person. But that otherwise could have been the worst day of my life so far. You see, that day, it was the first time ever that I was caring for a little child who died under my care. She was a beautiful little 7-year-old girl who each day lost more neurologic function until finally she was unable to breathe. And her family decided not to prolong her life, but to let her go gracefully and lovingly. And at the end of that afternoon, before I left the hospital, her parents sought me out. And they said they had something they wanted to share with me. They said that I taught them that her first breath was an utter miracle, and that every breath after that was icing on the cake. And they taught me, that I taught them, that it didn't matter if her life was 7 days or 7 years or 70 years. What mattered what was between the beginning and the end. And they wanted me to know that even when medicine didn't go the way we wanted it to go, that I had a gift to share with families of children. And so as I sat in the Arboretum, under the tree, with my feet in the stream, I realized that there might not be too many people that have that gift, and that maybe this was my calling, that maybe I was put on this earth to take care of these families, to walk the journeys that they didn't want to walk with them. And so, over the next couple years, I went home that night, actually, and tore up my application to another program, and I applied to pediatrics. I went into pediatric oncology, came here to Seattle to train. And in the first year of pediatric oncology fellowship, my friends Michael Jensen, Melissa Corcoran, and I diagnosed over 150 kids with cancer and cared for them and walked through the highs and lows that you can imagine come with pediatric oncology. And in many cases, families came to me and said, "You have a gift. We love what you do. You're so important in our lives." But there's one case where things went very, very, very differently, and I carried that with me. This was also a 7-year-old girl. But in this case, her neuroblastoma had spread to her bones, and when we went into a conference room with her family, her mom asked me, "So what does this mean?" And I'd been taught in medical school and in residency training to be honest with families, not to be patronizing, not to be protective, but to tell them what we know, what we think, so that they can make good decisions and can take their journey in good faith. And so I paused and took a breath, and I said, "I think this means that the cancer is going to take her life." And it did. And after that, I met with the mom and just wanted to talk with her like I do with all the families that I care for, to see how she was doing, how things were going for her, how things might have been different. And in contrast to a lot of the other feedback I had gotten, this mother stood over me, and she said, "Dr. Olsen, don't ever, ever do that again." And I said, "What?" And he said, "When you told us that cancer was going to take her life, you took away all hope. And you can never leave a family with no hope." And she punctuated those words by a few months later, killing herself. And so I carried that with me into each case that I cared for in the subsequent months and years. And you can imagine what that feels like when you come upon an x-ray like this going into clinic. And you see that in this beautiful brain of a child, there's a huge tumor. That big white thing in the middle isn't supposed to be there. And that's the brainstem that connects the brain to the rest of the body. In my 23 years of practicing oncology, I haven't yet ever had a child survive with this cancer. And so what does it mean when you stand outside the door and you're ready to walk in and meet the child who belongs to an x-ray like this? Imagine opening the door and finding a child like this. This is Kyle. He was also 7 years old. And going in and talking with him and his parents about this was one of the most difficult days of my life. When I brought his parents into a room and shared with them the information about his cancer, I tried to hang a little bit of hope on that we might know more by next year. I tried to hang a little bit of hope on that there are kids that we don't expect to survive that do survive. But when his father asked me, "Have you ever had a child survive with this cancer?" and I said no, his father slumped to the floor. And he was on the floor sobbing for most of the next 2 hours. And for those people who are not as good at filtering our emotions as most of us are, this is what it feels like to hear this news. And so I have one hope. And my one hope is that before I retire, that I can walk into a room of a child that has an x-ray like the one I showed you and offer them real hope, that we have a therapeutic that could save their life and allow them to grow to be an adult. Now, what makes me think, and what should make you think, that we have any chance of doing that? A lot of people would hope for something like that, but what makes you think that we could actually pull it off? Well, there's 3 examples of what our lab has done that set the ground for this. The first, we learned that a medicine that is traditionally used for treating acne, called Accutane, was as potent as our strongest chemotherapy for killing medulloblastoma cells, one of the most common and malignant types of pediatric brain cancer. We found that when we added the 2 drugs together, it was 6 times more potent than either drug alone in our laboratory studies. We brought that to a national clinical trial that I'm leading around the world in 250 sites, and we are hopeful and believe we're on track to change the survival rate for kids with high-risk medulloblastoma from about 55% to about 70%. That'll be the biggest jump ever for those kids, with a medicine that comes from vitamin A from a carrot. I was sick, really sick, of writing prescriptions for kids who had recurrent cancer, not having any idea if their cancer was already resistant to the medicine I was writing for. If I was writing them for a prescription for a drug that their cancer already was resistant to, that meant that for the next 3 months or 6 months, they were going to get toxicity from that medicine with absolutely no possibility of a benefit. And this isn't just kids. This is adults, and this is every type of cancer. We, as oncologists, don't have a way to know whether your cancer is sensitive or resistant to a drug. Okay? So our team, we invited some engineers in, and we invented a technology in which we can insert an array of needles into the tumor while it's still in the patient, and as we withdraw those needles, it leaves little tracks of drugs or drug combinations. And the next day when the tumor is taken out, we can cut it crosswise to the way we put the needles in. And you can see on the left what it looks like when a drug is working and killing the cancer cells. All those little yellow dots are cancer cells dying in response to that drug. And on the right is the same type of cancer, the same amount of drug, and 0 response. So if this was my mom and this was breast cancer, I would want her to have the drug on the left. If she had a tumor that looked like the one on the right, I would want her to take a different drug and not take that drug. We just entered clinical trials with this technology a few months ago, and we're using the same technology to work with drug companies to refine and optimize their combinations of drugs that they bring to cancer patients. The third thing that we've developed is a molecule called tumor paint. Some of you may have heard of this. This was inspired by this child that we cared for. On the left, you can see that it's when a patient comes and has an MRI scan and there's abnormality, you can see that there's a brain tumor there, but you can't see where it begins and where it ends. And right behind it, where the long arrows are, is the primary motor strip that connects the brain to the rest of the body and helps us make our movements. So the surgeon can't take out a big margin around this tumor because he will leave the patient paralyzed. Unfortunately, it doesn't get much easier when you get into the operating room. In the center, you see what it looks like to the surgeon right now. This is how they operate, with white light, using their eyes, their thumbs, their fingers to figure out what's cancer and what's normal brain. Who can tell me where the cancer begins and where it ends? On the right is what happened, in this case, after a Harvard-trained surgeon with 25 years of experience spent 17 hours trying to distinguish what is normal brain and what is brain cancer. And in tumor board the week after, we saw this MRI scan that shows that there's a thumb-sized piece of cancer left behind in her brain. The surgeon left there because he thought it was normal brain, and he did not want to hurt her. So now we had this terrible decision to make of, do we bring her back to the operating room? Do we do another surgery, another ICU stay, another potential chance of death? Do we proceed by giving radiation and chemotherapy, knowing that there are billions of cells there that could be resistant to the drugs or radiation that we use? And so that day, Dr. Ellenbogen, the surgeon who I told you about, came to me and he said, Jim, you and your team need to find a way to make these cancer cells light up so we can see them while we're operating. We did that. We developed a molecule that you see on the top panels that we inject into the bloodstream, it travels around the body, it finds the cancer cells, and it inserts a little molecular flashlight into the cancer cells and makes them glow so that surgeons can see them while they're operating. On the left is a mouse that doesn't have cancer in its brain, and on the right is a mouse that has a small amount of cancer in the back part of its brain called the cerebellum. And you can see that the part that lights up with the tumor paint is the same as the part that has the cancer in it in the image below. Likewise, when we use the same molecule to look at a mouse that had prostate cancer, and we were looking at the lymph nodes behind the prostate gland, we saw that every lymph node, labeled with N's in this case, that lit up was filled with cancer cells. And the lymph nodes that didn't light up didn't have any cancer cells in them. But there was one little spot, the one labeled with an L, that really didn't feel like a lymph node to me. It felt like a little wad of fat. So I sent it down with a note, said, this feels like a little wad of fat, but it's lighting up. And the pathologist called me back, and he said, you were right. It's a little wad of fat, but inside that wad of fat is a lymph channel. And inside that lymph channel are about 200 cancer cells traveling from one lymph node to the other. And with that information, we learned that this technology, that this tumor paint that we had invented, was about 100,000 times more sensitive than the MRI scans that we use, and that surgeons could use it in real time. It wasn't a static picture hanging on the wall that was taken 2 or 3 days or 2 or 3 weeks before surgery. And so today, I'm going to show you for the first time ever what this looks like to the real surgeon. We're now using this technology in dogs that have cancer at Washington State University. We've been working with 2 teams to develop new technologies to image these tumors. And I want to show you this now as we lower the lights and bring up the first image of breast cancer. 30% of women who have breast cancer find out that where the surgeon stopped cutting, there are still cancer cells, and that they probably need to have more surgery done. And unfortunately, they get this information 7 to 10 days after they're out of the operating room. That is not fair, and that can't be the way that we operate 10 years from now. This is a dog who had a sarcoma removed. And in this image, you can see that the surgeons knew that that bright spot on the bottom was cancer, but the surgeons couldn't tell that those other spots were cancer. And this, I believe, happens in every operating room every day in every city of this country. And I believe that the time will come when surgeons will look back and say, I can't believe we used to operate without being able to see where the cancer cells were. So this molecule that I've told you about, this tumor paint, uses a peptide, a mini protein that comes from the Israeli deathstalker scorpion as the targeting agent. I'm not able to tell you the whole story of how this works or how we got to this, but the bottom line is that we relied on this scorpion because I felt that this scorpion had millions of years to get it right. The scorpions who make the best drugs, the drugs that can get into the brains, that can affect neurons, are the scorpions that get to make baby scorpions, and they get to grow up and make best drugs, and they get to make, so there's pressures to make these good drugs. But the problem is that, scorpions is one thing, but there's so many other things that are out there in nature that could be making their own drugs. As I was riding, as we were on vacation in France a few years ago, I don't know how many of you have kids who like to sleep in longer than you do. My girls like to sleep in till quite late. They then like to wake up and spend about an hour and a half or 2 hours figuring out what we're going to do that day. And that kind of drives me crazy. So when we go on vacation, I rent a bike and I go out for a long bike ride, and by the time they wake up and decide what the day is, I'm coming back refreshed. And on one day I was out riding through the sunflower fields in Provence, France, and I noticed that every sunflower had perfect petals on it. And I thought, geez, if I was a bug, I would be going after those bright yellow petals that are filled with nutrition. Why are the bugs not eating those flowers? Well, it turns out that, like the scorpion, sunflowers can't go to Walgreens when they need a prescription. Right? They need to make their own drugs. So every animal and every plant in nature has ways to protect itself, and it has to make these. And I'm not talking about the kind of movies that we saw 10 or 20 years ago where the doctor goes to the rainforest and gets the droplets and finds the drug and cures humanity. I'm really talking about the drugs that are encoded in their DNA and that has had millions of years of evolution to evolve. In this case, the sunflowers make something called sunflower trypsin inhibitor that follows the same rules as the scorpion toxin and neutralizes the enzyme that a bug squirts on it to try to eat it. So people had the idea that we could turn these drugs from nature into drugs for humans 23 years ago. And over those 23 years, many groups have tried to develop drugs from nature, and most, if not all, have failed. Okay? I felt that we could potentially succeed, and the way that I think that our team will succeed is that I looked to put together a team that was like Kyle, that first patient that I told you about. Now, Kyle, while he was only 7 years old, was the most athletic and most competitive person I ever met. He would not take no for an answer. He would not lose. During the year or so that I was taking care of him that he had brain cancer, even with double vision and a big tumor like you saw in the back of his head, he won every ski race at Mount Baker that winter. The following summer, he scored more goals than all the other kids on a soccer team put together. Okay? This is Chris and Colin, who are members of my team that I hired to build this project to learn how we could take these scaffold drugs from nature and convert them into drugs for humans. Now, scorpions or sunflowers don't have any evolutionary pressure to cure cancer, to reverse autism, to prevent stroke, to cure bipolar disorder, or prevent the tragedies of Alzheimer's disease. So we have to take the scaffolds that come from nature and then use our human intellect and ingenuity and stick-to-itness to make candidate drugs. In everything that I do, I begin by looking at why other people might have failed. And we put together a list of 7 reasons that were barriers to creating tens of thousands or hundreds of thousands of drugs from these scaffold drugs that come from nature. And believe it or not, in less than 1 year's time, in 11 months, Chris and Colin overcame 6 of the 7 barriers that we had identified. This is amazing. No drug company had even come close to this. The problem was, with their success, we now found it immediately necessary to expand the team. All right? So now we put together the perfect team of what you've been hearing about today. Interdisciplinary, passionate, 100%, absolutely amazing team. One small problem. This team, to do the science that they're going to do in the coming year, would cost me about $3 million to $5 million. And there was no budget in that, particularly in the days of sequestration. Okay, so what do I do about that? I could write a grant to the National Cancer Institute. If I got it, it would take about a year to get it. If I got it, it would be about $200,000 to $250,000 against a $3 million to $5 million bill. And my likelihood of getting it is only around 10%. And it might actually be lower because all those other ideas that I told you about when I submitted on the first time, they did not get funded. They said this is too adventurous for us. And so they didn't get funded. So I could spin it out into a biotech company, but the problem is that 90% of biotech companies fail, and the reason that most of them fail is because people bring things out too soon. And I didn't want to bring this out too soon. I could rob a bank. But the only thing that I fear more than opening the door of a child who has a scan like the one I showed you is spending the rest of my life in an orange jumpsuit. And so instead we turn to the families, to our family, that have built all of these things that I told you. The children that I've cared for and their families, whether they survived or did not survive, have raised over $8 million to support tumor paint, the technology for identifying drugs that work and don't work, the Accutane, all of that. And so we thought we could move beyond that. We went back to nature and we thought, of all these plants and animals that create drugs, what's the one that really inspires us? And I love the violet. It's purple. It's passionate. It creates these drugs. And inside every passionate little violet, there's this little firecracker inside. And at the same time, I was taking care of a little girl whose name was Violet. And as you can see, she is also a firecracker. Now, Violet also had a brainstem glioma, and she knew she was going to die. She was not afraid of death, and she and her family asked if, at the time of her death, we could take her to autopsy and to remove her brain tumor and to create research tools from it and share them with scientists around the world so that other kids would not have to go through this in the future. And in all the years that I've been in academia and places where people do good work, I've seen buildings named after wealthy donors. I've seen stadiums named after wealthy corporations. But I wanted this most exciting science that I've ever done in my life to be named after a child who could give like that. And so we began Project Violet. And with Project Violet, we began a process where people can adopt one of these drug candidates that we make. Of the 6 barriers that we overcame, we went from being able to make 12 of these drugs per year to being able to make 10,000 in 3 weeks. Okay? So people can adopt one of these drugs for $100 and then begin the conversation with us. They can tell us what they want us to work on. They can hear about the progress of our scientists. Through Project Violet, they can be in constant touch with the scientists on our team. And people said, why don't you just use Kickstarter? And we just said, this is Project Violet, this is different, this is our own thing, this is our family, these are our patients. And in the 1 month since we started Project Violet, even though we only shared it with friends and family, we've raised enough money to pay for several of the salaries that I showed you up above. And today with this talk marks the national launch of Project Violet. So people often ask me, if you're a pediatric oncologist, don't you have to put up walls of emotion so that you don't feel this from these kids? And I say, no, I let myself love every one of them because that brings in all that rich life. I get to be part of their lives. I get to love these children through the highs and lows. We go through it together. That's the beauty of what I do. And today I'd like to be able to share that with you. I'd like to welcome you to share that, to become part of our family. In the spirit of good TED Talks, if you feel this is an idea worth spreading, I welcome you to share this talk with your friends, or share the Project Violet website with these friends, and share in my dream. Thank you.